welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell and many more. We have not forgotten to include within our health hours the many societal, cultural, religious and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you and we want you to use the time to listen, learn, share your experiences and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.
Okay, good morning. Nice to see all of you today. Thank you so much for joining us and giving up your time to join us at the Caribbean African Health Network Health Hour. My name is Ngozi Ediosage. I'm a neonatologist and I work in Manchester. You could have been anywhere doing anything, but you've chosen to be here. So I consider it a great privilege to be able to introduce our speaker to you this morning. He's no stranger to Health Hour and he's been here numerous times before. It's Mr. Theophilus Asumu, who's an orthopedic surgeon, a consultant at Manchester Foundation Trust, which happens to be the trust I work in as well. So hi, Theo, and welcome back. And he's going to be speaking today about common knee problems. So if you've got any questions, this is a session for you. So please pop your questions in the chat, can raise your hand, and we're looking forward to a session. So thank you, Theo, and go ahead.
Thank you very much, Ngozi. Just to confirm, we're going for about an hour, are we?
Yes. So what we usually, as usual, we would. It's about an hour 15 minutes.
Yeah.
If you speak for maybe about half an hour, gives an opportunity for people to ask their questions. But I'm sure you've got so much knowledge about this that you're such an expert. That I know that this will be a really great session, and you can preempt some of the questions if there are things that people don't even know they don't know.
Okay.
You can let us know. So thanks, Theo.
Right. Thank you for those very kind words, Ngozi. I will try and share my screen. I've got a presentation I'd like to work off, if that's okay. And if I can. So I'm going to be talking about
yeah, you go ahead and share your screen.
Yeah, I'm going to be talking about common knee problems. And just let me know when you're able to start seeing that. I think you should be able to see it now.
Yes, we can see it now. It's still on, it's not on the slideshow. It's showing all the slides. If you want to put it on the slideshow mode.
Yeah. Okay. Oh, so I think I'm finally there.
Great. Yes, you are.
Okay. Yeah. So thanks for the introduction. So my name is Theophilus Asumu, and my origins are from Nigeria, which is where I did my basic medical training. And then I came to Manchester sometime in the early 1990s and pursued a postgraduate career in surgery, specializing in orthopedic surgery. And I've been a consultant in orthopedic surgery now since 2000. I initially started working in Oldham, and more recently, I've been working at North Manchester General Hospital, where I chair the division of surgery. The reason I'm talking about common knee problems is that I do have a particular interest and focus on knees and knee problems, and that is my chosen special interest. And it's the vast majority of what I've devoted my professional life as a consultant to doing. And the patients who are sent to see me come in two main groups. One are those who come having had an injury to the knee, and I will talk about the injury patterns that we see. And there are those who come through their general practitioner because they've had some pain or stiffness, etc. I'll go through what I think are the more common presentations, but please feel free to ask questions on anything really about the knee in the question and answer session. And in fact, anything more generally about orthopedic surgery, broken bones, sprains, trauma, I'm happy to take questions on that. So what I'm going to do is spend some time talking about the structure of the knee, because I think that's important. And just a very basic overview of what structures there are in the knee. And that helps build on later on when I talk about what can go wrong when you have an injury to the knee or when you present with a painful knee. So the knee, there are three major bones in the knee. You have the femur, which is the thigh bone. The lower end of the thigh bone meets the top end of the shin bone, which is the tibia. And then in front of it, you've got the patella, which is the kneecap. So the image on the left-hand side shows the knee as you would see it when you look at it from the front. And the image on the right-hand side shows what it looks like when you look at it from the side. There's another bone which is on the outer side of the knee, a very small bone called the fibula. That doesn't take part in the knee joint itself. It can cause some problems with pain around the knee, and it is where some of the ligaments in the knee attach. The lateral ligament attaches to the top of the fibula, but it doesn't take part in the main knee joint itself. So those are the three major bones that make up the knee. If you take an X-ray, you will find, you can see the three major bones in the knee. And we usually take X-rays in two views, one from the front and one from the side, just like the images show. And those are the standard kind of X-rays you will have if you have any knee problems or if you turn up in the emergency department having injured the knee. Important to note in these X-rays is that you can see the bones quite clearly, but that's about it. You can only see the bones. You can't see anything else. If you look at the X-ray on the left, you see that between the two bones, there's something that looks like a gap. It's not really a gap. It's just that there are things there that don't appear on X-ray. This is important because if you have an injury to any of the other things in the knee, apart from a bone, which will be demonstrated on the X-ray as being broken, an X-ray will not be able to show you where the injury is. So there's cartilage in the knee, but quite importantly, there are two types of cartilage. And so any joint in the body where two bones meet and there's movement happening, like the fingers, the shoulders, and things like that, you don't have a bone meeting a bone because bones are quite rough. So there's a smooth covering over those bones, which is cartilage, and it allows the joints to move smoothly when you have normal cartilage. So that's what we call articular cartilage. Articular just refers to the fact that it is within a joint. And that's in every joint you have in the body, well, the vast majority of joints. The knee itself is special in that it has some extra cartilage within the knee. And the additional cartilage is really to help the knee absorb some of the shock that it gets. So the cartilage you find on the inner side and on the outer side, there are two of them. They're shaped like C's, like a crescent, like, the moon when it's not quite a half moon. And they're called the meniscus or the menisci. So you have one on the inside called the medial meniscus and one on the outside called the lateral meniscus. I think it's important to appreciate that there are two different types of cartilage in the knee. One is articular, covering the top of the tibia and the bottom of the femur, and that is in every joint. And the second is the meniscus, which isn't in every joint, just in the knee. And that's for shock absorption. Because when we talk about a damaged cartilage, it could be either of those two. Although most people would refer to a torn cartilage as a torn meniscus, but it's important to find out if your doctor tells you there's a problem with the cartilage, what cartilage they're talking about. You've got ligaments as well. And those basically stop the knee from moving in every single direction. They stabilize the knee and make sure that it moves largely like a hinge, so moves forwards and backwards. And you've got a ligament on the inner side of the knee called the medial collateral ligament. A ligament on the outer side of the knee is the lateral collateral ligament. Then you've got these two ligaments which crisscross in the middle of the knee. And they are your cruciate ligaments, anterior and posterior. You will often hear, if you watch Premier League football and things like that, someone's damaged their cruciate ligament because they're quite significant injuries, those. They take a lot of force to damage them. In terms of muscles, you've got two main muscle groups. There's the muscle groups at the muscles at the front of the knee, the quadriceps or your quads. And then you got the muscles at the back of the knee, which are the hamstrings. The quadriceps changes from being a muscle to being a tendon just above the kneecap. And that's the quadriceps tendon. And then just below the kneecap, it's the patellar tendon. And the tendon holds the kneecap to the shin bone. Important thing about tendons, they don't really stretch. Muscles are elastic, they stretch, they contract, and they allow you to move forces. But tendons are quite stiff, and they just serve to attach the muscle to the bone. So that's a brief run through about what the knee structure is. So if we take a look at injury of the knee, I'm not going to deal with fractures. I spend a lot of time treating knee fractures, and I'm very happy to answer questions related to knee fractures, either to a native knee or on the knee replacement. But more importantly, the patients I see who tend to have a lot of problems, tend to have a delayed diagnosis, are those who've had an injury to the soft tissues, those that don't appear on an initial X-ray. And that's if you have a ligament injury, an injury to the meniscus or cartilage, an injury to the muscle or tendon. Those are often poorly diagnosed. At the time I started working in Oldham in 2000, there was the average time between getting an anterior cruciate ligament injury and having a diagnosis that this is an anterior cruciate ligament injury was about 2 years, because it just wasn't recognized that well. And we went through different processes, and I ended up setting up a knee injury clinic, which basically meant we never misdiagnosed this, or at least very rarely ever, because patients do suffer if you can't tell them what's going on. And in terms of knee pain, it's largely related to your age, and through various age brackets, types of causes of knee pain will vary. So starting with the injuries, most knee injuries are related to sports, at least in the setting in which I practice in UK. Most of them are related to sports, mostly related to football. And that's just because football is a very popular sport, especially for men, more so for women nowadays. women do have a higher risk of knee injuries in football just because of the slightly different anatomy they have. Also, there's a cluster wherever you have a netball league, then you do tend to find a cluster of knee injuries related to netball. I don't understand netball. I couldn't recognize a netball if you showed me one, but enough patients have told me that they injured their knee playing netball. I recognize it's a problem. Now, if you have an injury whilst playing football or badminton or rugby, it's difficult to make a diagnosis and tell you what's happened. Apart from the fact that your knee is injured, it's painful, it's swollen, and you're limping. And most of the time, it's a non-specific injury, and it should respond to something we'll call RICE, which is rest, ice, compression, and elevation. Pair of crutches, when it gets better, have some rehabilitative physiotherapy if required. And after 6 to 8 weeks, most people are okay. And this is how we treat what I would call the general population. For people who have much higher demands, who can't afford to wait for 6 to 8 weeks to see if they'll get better. So if you're an elite sports person, if you're a tennis professional, if you're a Premier League player, then you don't wait. You get an early diagnosis with an MRI scan, because it is actually, well, I say almost impossible based on your initial x-rays and the physical examination of the knee to say what the problem is. The knee is just too painful to examine properly to localize the ligaments and the cartilages, which might be causing problems. So if you have common things like a sprain of the medial collateral ligament, then that would normally resolve after about 6 or 8 weeks, and then things are okay. If after 6 to 8 weeks you're still having problems, then we start to wonder. You would have had an x-ray, and the x-ray would have shown us that you don't have a broken bone. Is it a meniscus or a ligament? Those are the two more common soft tissues to injure. And the common problems that people would complain of at this stage is that maybe they have swelling in the knee or recurrent swelling. So they've had some swelling, it's gone down, and they've stepped awkwardly over an object or coming out of a car, and they've had more swelling. And that recurrent swelling tells you that there's something going wrong. They can complain of locking, and that is, without warning, they are just walking along and the knee suddenly jumps in a particular position and they can't straighten the knee fully. And if locking continues, then it's a problem that needs to be addressed. Instability is largely related to the knee giving way in certain vulnerable conditions or feeling like it's going to give way. That is, maybe you try to return to playing football, decided to start off in goal, and when you thought you were going to try and make a save, and the knee felt very unsteady, so you thought, right, I'm going to stop. So that's instability. Or persistent pain, which is, it doesn't show a progressive improvement, or it improves and then worsens, improves and then worsens. When you have this level of symptoms 6 to 8 weeks after injury, then you should really be having some more diagnostic tests. And the most useful one is an MRI scan. And in UK practice, MRI scans should be very easily accessible to all general practitioners and most physiotherapists, and certainly all orthopedic surgeons. And the difference between an MRI scan and a standard X-ray is that it shows you the soft tissues. So you can see cruciate ligaments, you can see muscles, you can see fat, you can see the surfaces of the knee in much more detail. And if there is an injury to a meniscus or a cartilage, then an MRI scan will be able to give you an accurate diagnosis. There are times when an MRI scan done too early within the first 24, 48 hours might be very difficult to interpret for some radiologists because there's a lot of injury in the knee and it's difficult to say what exactly has been damaged. But after 6 to 8 weeks, then the picture is a lot, well, certainly within 1 week, the picture is a lot clearer on an MRI scan. But after 6 to 8 weeks on physical examination, we can actually give you a much better indication as to what the problem is. But before you have any intervention, an MRI scan is pretty essential to give you a roadmap to the inside of the knee. So if you have a meniscus or ligament injury and you see your general practitioner, you should really be referred to a specialist, either an orthopedic surgeon or a physiotherapist. And they will then start whatever rehabilitative treatment you need. And most likely, if you've had an injury at sports and you've had a meniscus or ligament injury, you will likely end up having some form of surgery, which is usually a keyhole operation. Ligament reconstruction can be done through a keyhole operation. If you have more major ligament damage, at times you might have an open operation to get the knee stable. But if you're having problems in that time frame, then that's what you should expect when you see your doctor. Now, a word about meniscus injuries in those who are over 40. If you've had knee problems and you go to your GP and they arrange an MRI scan, and the result says that you have a cartilage tear, and it's not been due to a sporting injury, then it's a different pathology we're looking at there. So that's more like a meniscus that's just aged and has started to crumble. And it's usually not due to sports, but usually people can tell you when the pain started. And common is when the knee has been put in a position where you've placed additional stress on it, such as when you're squatting, because that places a lot of stress on the knee. So people might tell you that they were gardening for most of Saturday, it's been a good day. And then as they got up, they felt a sharp pain in the knee. Next day, the knee looked a bit swollen, limping a bit. It's not really getting better. A few weeks, you see your GP and an MRI scan shows that you've got a meniscal tear. Those tears tend not to respond very well to a keyhole operation, even if they are taken out, because the problem really is that the cartilage is weak and crumbling and will continue to crumble. So usually physiotherapy is what's advised for that pattern of knee injury, at times some knee injections. I mention this because it seems counterintuitive when you say, I've got a painful knee, the scan shows there's something torn, but I'm not having an operation to deal with that torn thing, because over time we've recognized that these don't actually have a very good track record when you operate on them. What about childhood? Knee pain in childhood is uncommon. It happens, but it's uncommon. There's a whole host of causes of knee pain that come under the umbrella of growing pains, and those are just non-specific aching in the joints that improve over time without any treatment. There's some children who are very sporty, and if they go too far too fast, they can start to have problems with the tendons and where they're attached to bone. So if the muscles get very strong, but the bones are still relatively weak and haven't stopped growing yet and haven't fused, you can get the tendon pulling very hard on the bone and causing inflammation. And usually that bump on the front of the knee, just under the kneecap, in front of the shin bone, you can get pain in that area. And that's Osgood-Schlatter disease. It's one of the more common causes of knee pain, more common in boys than you find in girls. And really, you just have to moderate the activity and allow the bones to catch up. And once the bones stop growing and they're fused, then you can go back to normal activity. Unfortunately, that means that you might have to wait until you're about the age of 16 before going back into high-level sports, which can have implications for certain people, depending on what your aspirations are and your skills. In early adulthood, I mean, the most common cause of knee pain is the trauma we've been talking about, the sports injuries. So I won't talk much more about those. But you can also have, once again, tendinitis, or things we call bursitis. And that's inflammation of these structures called bursa. And a bursa is just a sac of fluid that is between two rigid objects and allows gliding between those rigid objects without friction. So you've got them in lots of places around the body, and a lot of them around the knee. So you've got a bursa at the front of the knee, between the kneecap and the skin, to decrease friction there. You've got another one in front of the tibial tubercle. You've got one on the outer side of the knee. On the inner side of the knee, you've got one as well. And many of these, when you do repetitive activities, so you've got conditions where you get enlarged bursa in people like, clergymen who kneel a lot. And in the old days, we used to refer to housemaid's knee, because you had housemaids who were on their knees scrubbing the floor. But I guess with the vacuum cleaner, we don't do that anymore. You can have bursitis on the outer aspect of the knee from cycling, so repetitive knee flexion and extension, where you have a band of tissue on the outer side of the knee. Those are the more common causes you start to find in early adulthood. Most of them can be treated with anti-inflammatory medication or physiotherapy or activity modification. Very rarely do you require an operation, unless you have a persistent, unsightly, enlarged bursa. If you have arthritis in the knee, every now and then you'll find a swelling at the back of the knee called a Baker's cyst. And people don't like the appearance of a Baker's cyst. But there's not really much you can do about those cysts, because the problem is the knee is arthritic rather than the cyst. And so if you take that cyst out, it will just come back. And so the general attitude we have is to treat the arthritis based on its own merit. So you might have painkillers or injections rather than having the cysts taken out. In later adulthood, if you're over 50 and you've got knee pain, then until proven otherwise, I can tell you over the phone that it's arthritis, and I'll be right 9 times out of 10. And if you have arthritis in the knee, the diagnosis is fairly straightforward for any healthcare professional you see. An X-ray will show that the cartilage on the surface of the knee, the articular cartilage, has started to wear down, and the bones are starting to touch. So the bones themselves should never be in contact with each other. They should be separated by that cartilage that is smooth and allows the joints to glide. So when you start to get that wearing down and you have bone-on-bone contact, it gets painful, and there's stiffness, and the movement is impaired. And at times you might find that the knee becomes, you become either knock-kneed or bow-legged, depending on the pattern of arthritis. At times, you don't notice much of a change in the shape of the knee, but the diagnosis is fairly straightforward. This is an example of a patient who has some deformity in the knee and has arthritis. And the reason she has the deformity is related to a previous fracture. And that's almost certainly why she's developed arthritis. And at times you notice recurrent swelling in the knee, and you can get flare-ups of pain where it gets much more difficult to function and do your day-to-day activity. Arthritis is quite common. If you're over 65, it's about 30% of people who have arthritis in a joint, in one joint or the other. And at times the symptoms can be quite disabling. So, and it's strictly age related. Every 5-year and 10-year gap, 10-year age bracket you get more and more arthritis. So it's something that takes you to see your doctor more and more frequently, and has a high health impact. Not because it has anything to do with your life expectancy, but it's the quality of your life and your ability to remain independent. Treatment options for osteoarthritis is, in the early stages, we follow what we call a ladder. So we do the least invasive thing. So if you can look at your lifestyle and advise you on, should you stop playing football? Should you stop running marathons? Do you need to lose weight? Should you use a walking stick? Physiotherapy can help maintain muscle power and range of movement. And in terms of activity, we advise you to remain as active as possible without causing more pain. When we've done all that, then we start looking at medication. Do you need to take frequent paracetamol? Do you need some anti-inflammatory medications or codeine? And then injections, joint injections, usually cortisone injections. There are some other injections that are helpful for knee arthritis, but they're not available on the NHS, unfortunately. Some other healthcare systems would have them available because there are some drawbacks with regular steroid injections. And then there's surgery. For the knee, there's a whole host of operations, but for fairly severe arthritis, what we usually advise is to have a knee replacement. So the options of having keyhole surgery, joint realignment, joint fusion, we very rarely do that now for arthritis, very rarely, if ever. And usually we will only fuse a joint if a knee replacement has failed on a number of occasions. But joint replacement is very successful. I think over 100,000 will be done in the UK this year. And with fairly good survivorship, actually. So we'll come back to this patient I told you about previously. These are her x-rays, quite bad arthritis. But if you put in knee replacements, she was very happy with this. And, you know, they often say it changed my life, or it gave me a new lease of life. So it's quite a successful operation. No operation is universally successful. And knee replacement remains a major operation, which can have side effects or may be unsuccessful. So it's not to downplay how invasive it is, but it's there. The reason I make this point is that we seem to be somewhat unwilling to have joint replacements. And in my practice, I very rarely perform a joint replacement on a non-Caucasian, very, very rarely, despite the makeup of the population that I treat as a whole. So people from ethnic minorities still don't have hip or knee replacement surgery at the same rate as their white counterparts. There's a variety of reasons for this. We're not exactly sure what the reasons are. Some might be due to access reasons to the general practitioners. Some might be due to understanding of what options are available. Some might be because you don't really know people who've had it done, and you might have heard some bad stories. But there's some more work going on into why we're not as accepting of this type of non-emergency surgery as white counterparts. So there are a lot of other knee problems that I haven't talked about, but I'm happy to discuss rheumatoid arthritis. We've talked a bit about tendinitis. You can have your kneecaps dislocating. That can be a real problem. At times the kneecap maltracts. You can just develop knee pain in your teens and early 20s, and you get told after a scan you've got osteochondritis, and that's bits of the knee breaking away. You can have abnormally shaped menisci, cartilages. I mentioned a bit about Baker's cyst. So there are a whole host of other problems, but I think I've tried to talk about the ones that I've found most common will present to me in the outpatients clinic. So I'll end by saying that if you have a knee injury while playing sport, it will usually settle. And if you're advised to just wait it out and have some anti-inflammatory medication, etc., you're not being ignored. But you do need to look at the knee and ensure that it's going back to the level you want it to perform at after about 6 to 8 weeks. Otherwise, you need to have further investigations. If you overuse the knee, you can get pain. And it's just your body telling you that the particular type of knee you have isn't designed to support the activities you want it to support, because everyone's individual. And at times it's probably better to listen to your body. After the age of 50, if you got a painful knee, it's arthritis until we find another reason. But effective treatments are available. So make use of them. I think I'll stop sharing my screen if that's okay, Ngozi, and I'm happy to take any questions.
That's fine. There's been a number of questions put in the chat as well. So I'll go through some of them, but thanks very much for that talk. I was listening for myself because I've run a marathon and I'm planning to run another one. So when you said lay off the marathons, I didn't know what to make of that.
So I can address that really. It's confusing what we know about marathons and knee pain, especially knee arthritis. What seems fairly certain is that if you already have changes of knee arthritis, then continued impact running will make that arthritis get worse quicker than if you didn't do the impact running. Okay, so if you waited 5 years with your knee, if someone has knee arthritis, waited 5 years and didn't do any marathons, the knees would be better than if you did marathons in that time. If you don't have arthritis, though, it seems that it's actually not a problem. So it seems actually that long distance running and high impact activity isn't a problem if you haven't sustained injuries and you don't have arthritis. And also there's also the thing that many runners enjoy running.
Yeah.
And it improves their mental well-being and their physical well-being. And so if you were to stop running altogether, you might protect your knees if you have arthritis, but overall, I think you'd be worse off. And what you must do if you're going to stop running because of arthritis is to find something that you enjoy as much as and doesn't harm your knees, and you will continue doing. Otherwise, if you just stop running, then the weight piles on, your heart health suffers and your mental health as well.
Okay. Just before I come to the hand up, there's some questions that were put in the chat, so I'll just address some of them first. One is that this lady's been diagnosed with osteoarthritis, and the question is, what's the best to rub onto the knee? And is there anything you can drink to protect your knee from or to treat the osteoarthritis?
So we would normally start with tablets that's considering all the lifestyle factors I've talked about have been taken care of. We'll normally start with tablets by mouth, unless there's a reason you can't take tablets by mouth. Because what we're trying to do is to get some pain-killing medication into your system. They are more effective by mouth than when they are applied locally. There are some reasons why some people can't take them by mouth, and that's fine. And if you can't take them by mouth, then you can try them topically. And a topical anti-inflammatory cream like ibuprofen gel or Voltarol gel will be fine. If there's a reason you can't take ibuprofen or Voltarol or things like that by mouth, then be aware that there's some absorption into your system when you rub it onto the knee, and you may well run into those problems. So you need to watch out for the same side effects, although you're much less likely to get them. Then there are some preparations that they're not available in an oral form, and they're available purely by creams because they work by a different method. They irritate the skin and they distract you from the pain of the knee. They are based on a peptide product. They're called capsaicin cream. And those are quite good for knee pain, but they're not first line. They're not first line treatment. In terms of what you can take or drink to improve osteoarthritis, there's some evidence, not very good evidence, but there's some evidence for taking things like glucosamine, which can be obtained over the counter. Glucosamine at a dose of 1,500 milligrams a day. So if you take glucosamine on a regular basis, it can build up the cartilage on the surface of the knee if you have arthritis. Because of the way it works, it takes a while, minimum of about 3 months for you to notice any difference. Minimal side effects because it's an over-the-counter preparation, and you can get it in the the health section of Tesco, Asda, Holland and Barrett's, or Boots, wherever you want to go.
Okay. Thank you. I'll go to our viewer who's got their hands up. Do you want to ask your question?
I think you're muted, Anne-Marie. I don't know if you're saying anything.
I know, I'm trying to unmute it.
That's fine, thank you.
I'm so used to Zoom. You can't believe I still can't unmute myself. Yes, that was my question that I asked about the. I was hoping you would say quite a lot of other things you can rub with. I mean, I've been diagnosed with osteoarthritis, but it's only over the last 4 years.
Yeah.
My problem is I get lock-in. Well, I used to get a lot of lock-in in the left leg, left knee, and that's more painful than the arthritis itself. But I rub a lot of things on there, like natural ginger oil, clove oil. I went down that route, and that does not lock so much now. The arthritis is in the right knee, and that is very painful. That is very painful. But I've only been diagnosed with an X-ray. So are you saying I should have a MIR, because I was not offered an MIR?
If your specific symptoms are due to lock-in, then I mean, if you were seeing me in the clinic, I would want to just ask a few more questions. If by lock-in you mean that the knee suddenly jams in a particular position and you can't straighten it fully, then I'd be keen to get an MRI scan in case you have a loose body within the knee. A loose body made entirely of cartilage won't show up on an X-ray. And if that's getting caught in between the knee at certain times, it's very painful. And at least an MRI scan will give me some reassurance as to whether or not that is there. If you have a loose body that is causing lock-in, it's one of the reasons that I would advise you to have a keyhole operation, to have that loose body retrieved and taken out. Is one of the few indications for a knee arthroscopy in arthritis. The other reason for lock-in could just be that there are two parts of the knee that have no cartilage on them at all. And depending on how your knee moves, if those two bits come in contact with each other, it sends a sudden sharp pain, and the muscle is just going to spasm to protect the knee. And very slowly, you can then straighten the knee out. It can be difficult to decide which is happening. So an MRI scan is certainly useful to see whether you have what we call mechanical lock-in due to something floating around into the knee, or whether it's just the pain from the arthritis causing the knee to lock infrequently. In terms of the alternative non-pharmacological medicines you've mentioned, I haven't gone into that because we don't use them in clinical practice, simply because we don't have the evidence, the proper scientific evidence basis to make those recommendations. That's not to say that they don't work for people.
Yeah.
Thank you for your question.
Oh, sorry, I just wanted to say, but what about the knee with that has been diagnosed with osteoarthritis? Should I have an MRI or because this is the one that's really kills me, and I use a walking stick as well for the last 2 years.
Yeah, so if that's the one that's lock-in, then certainly
no, it's the left leg, it's the left knee that locks, which don't lock so much now since I've been rubbing it. It's the right knee that's been diagnosed with osteoarthritis.
An MRI scan won't add much. If you've
All
been
right.
if it's just pain in the knee and there's no locking, no mechanical symptoms, an MRI scan will show that there's arthritis, which you know already. It will show that there are cartilage tears, which will just is part and parcel of arthritis. So there's nothing much to be gained from an MRI scan for that knee.
Okay, and can I not ride my bicycle anymore because I'm 63 and I've been riding my bicycle for the last 40 years. So shall I not ride it anymore, or it eases
So
the pain when I ride it?
Riding a bicycle is low impact.
Okay.
There's not you're not really causing a lot of shock load into the knees.
Yeah.
I would encourage you to keep riding your bicycle for as long as you can, as long as you can keep up with it, because it exercises the knee.
Yeah.
And it's a good low impact activity. Cycling, swimming, those are very good.
Right. Okay. Thanks very much. Thank you.
Thank you. Thank you for your questions. I'll just go to some of the few that have been put in the chat before I come to the verbal questions as well. So this is a question about somebody who's had a Baker's cyst and it's really painful and they're struggling to squat and climb stairs. Would you know the best way that that's going to heal or how to manage this? What is a Baker's cyst? So this person knows what it is. I presume you do as well, but I don't.
A Baker's cyst is a small, it's a swelling at the back of the knee. Okay, so between those two tendons, you can feel at the back of your knee. And it varies in size from, being fairly small to being maybe the size of an orange at the back of the knee. And it's excess fluid from within the knee. Something's irritating the knee, and it forces the fluid out into that cyst. We don't advise having them excised because they just come back. The problem is within the knee. So if you take them out, they have a high risk of recurrence. Plus, the approach to get the cyst out of the back of the knee is there are lots of major nerves and blood vessels, and there are some really difficult structures at the back of the knee. So as a whole, we don't advise having them taken out. Treating the cause of the problem within the knee can usually improve the size of the Baker's cyst. And most people with Baker's cyst will say that they increase in size and decrease in size. If it's a particular problem, then one consideration can be taken to draining it under ultrasound guidance. So you put a needle in, which is safer, and you drain it out. Well, because of the reasons I said, it's temporary. And if you drain it, over time, you're likely to get the cyst fill up again. Okay. So we concentrate on controlling the problem within the knee that's causing the cyst, which is usually arthritis.
Okay, thank you. Just before I go to the next questions, there was something you said about the number of people who have knee replacements, and you find that they're much less amongst Afro-Caribbeans. Is that due to the pattern of referral? Because I presume that people that come to you they're not self-referrals, they've come from their GP.
Yeah, they've come from their GPs or specialist physiotherapists, and I just don't see them being referred. So they don't get through the front door to see me.
So is it not
of 100 patients that I would see that need a knee replacement, maybe 10 or 15, maybe less. I'm just trying to think off the top of my head now. Would say, you know what, not this year. Maybe let me just go and think about it, or I'm frightened or whatever. Okay. So I'm not saying lots of Blacks being referred in and refusing to have surgery. I'm just not seeing them.
Okay. So that means that there's a problem with the inflow then.
Yeah, the inflow. So it's many times if you have arthritis which is worsening and you've been seeing your doctor for a few years, they may mention, do you want me to refer you to hospital to see, maybe to have a knee replacement? I don't know whether that discussion takes place and whether there's a refusal at that stage, but I just don't see them coming through.
Okay. So, this is why I feel that these sessions are so important. They're here for you to empower yourselves, so that if you are having those knee issues and you are seeing your GP and you haven't been referred and you think you need to be referred, then please, when you go and visit next time, you do that, because it's I think it's abhorrent if there are people out there that can benefit from having knee surgery, but not even being given the opportunity.
So, Ngozi, let me just say that as a rule of thumb, if you're being woken up at night because of your knee pain, you're qualifying for a knee replacement. Okay, so if your sleep is interrupted because of your knee pain and you know you have knee arthritis, then if your x-rays match up, you will be considered for a knee replacement. So if you have symptoms of that degree, you're walking, you can't walk a mile without knee pain stopping you, then you should certainly be asking whether a knee replacement is an option.
Thank you. I can understand, sometimes the concern, the fear, but you as the expert will have seen people before and after. And I sometimes have this feeling that, once, this is what nature gave me, once you touch it, that's it. It's never going to be the same again. And I'm a medic, so I can understand the hesitancy, but at least for people that are here, just go and get checked out, because I've seen people who have described the pain they were in from a hip joint, and then they get a hip replacement and they're fab. Well, look at that tennis player.
Andy Murray.
Andy Murray, yeah, with his 2 new hips, and he's now winning titles again. Anyway, I'm going to go to Becky. I thought that was amazing.
It is amazing. Andy Murray is amazing, not the hips.
Him and the hips, and the doctor who did the hips as well.
Yeah.
Hi, Becky.
Hi, how are you?
We're fine, thank you.
Oh, yeah. Thank you so much to give me this opportunity. I have been suffering from arthritis on my right knee more than 1 year. Now it's 1 year, 3 months. So I have been going through physio. I have been taking some painkillers. I have been taking the cream, to rub the cream on my knee. Sometime, and then from where it started, it has there is improvement, but meanwhile, sometime there is a time I wake up, I feel it's like it's healed, it's okay. After then, the next day, I will feel the pain, and the pain I feel inside is like a bruise inside. The pain I feel inside the knee is a bruise, is a hot, like, when something hits you, that's how I feel under my knee. And I have been going to physio. I have been going through different exercise to improve my knee. There is improvement from, if you count it to 10, I'm on the 7. So I need to know what I can do, because they have been there for too long, and then I don't know what to do. Sometimes I get upset.
Yeah.
Thank you for your question, Becky.
Yeah, thank you. Arthritis can be, is very painful. It seems like you've been taken through the correct steps, though. When you say pain level of 7, I read that to be 7 out of 10, which is quite high. And you've had painkillers, you've used creams, you've had physiotherapy, and if you say there's improvement, my attitude generally will be, should we try and see if we can continue that improvement? So what happens with arthritis is the level of arthritis in the joint, if it remains the same, causes different types of pain at different times. And that's the funny thing about arthritis. So people are okay for periods of time, and then you get a flare up. As time goes on, and as arthritis gets worse, then the amount of time you're without pain starts to shrink, and the amount of time you got pain starts to increase to a level where you're maybe in pain all the time. So the question is whether the non-operative treatment that you've had so far is controlling it adequately, or whether it's time to abandon it and say, should you have a knee replacement or some sort of surgery? In considering whether you should have surgery, if you're referred to see a surgeon, they will look at your x-rays and try and work out whether all that pain is coming from the knee, because that's what can be replaced, the knee. At times, there are components of the pain that come from elsewhere, maybe the bottom of the back commonly. And if you've got pain from the bottom of the back contributing to knee pain, then that doesn't work very well. The other thing that people will take into consideration is your age. And if you're about 65 or above, people are much more willing to proceed with surgery like a knee replacement. If you're 50, early 50s or younger, then we're more hesitant because of the lifespan, and we know that they likely need to be exchanged in a few years' time. So those are all the considerations that people will take into account. But if you got x-rays that look bad and you're not being adequately controlled with pain levels of 7 out of 10, then certainly at that stage you start to think, is it time I see a surgeon so I can just explore the options?
Theo, how long does a knee replacement last?
So knee replacements, we have very good data on knee replacements. That's what we can say. We've got data on over 1 million knee replacements in the UK, and every knee replacement that's done in the country, wherever it's done, is registered into a joint registry, which is linked to the patient. And if that knee replacement comes out, that is also registered, and you can tell how long it's been in. So most knee replacements, after 10 years, 90% of them are still functioning.
Oh.
After 15 years, it's 85%. And going beyond 15 years gets more difficult because of the age profile at which many of them are done. So there's no reliable data going out beyond that. There's more small scale data, but they last quite long. The problems we have with knee replacement is not so much the longevity, it's the function. They don't function as well as hip replacements. So there's this thing called, we call it a forgotten joint. People forget they've had a joint replacement. With a hip replacement, up to 9 out of 10 people will say that they've forgotten about their hip replacement. In a knee replacement, is 1 out of 3. Okay. So it's not quite the same. So the older you are, the more likely you are to have a forgotten joint, because you don't need it to do much. But if you're much younger and you're quite active, you realize that it's an artificial knee.
Okay, thanks. Okay, we've got, before I come to the next hands up, I'll just go through some of the questions in the chat as well. This is a question says, I usually do exercise on my knees and hands, and I also pray whilst on my knees, but they've had to stop doing that now because of the pain when the person gets up. And there's sort of pain when they are on their knees with their legs stretched. Sounds really specific. And what they've asked is there any advice about what they might be doing wrong? Or what could be wrong with their knees, rather?
Yeah. So there are two patterns of, two groups of people I know who pray on their knees. Ones are in the Christian fashion, and those generally tend to pray with the knees at about 90 degrees. If you see what I mean. So you're just kneeling down. And then you've got the Muslims who tend to go with their knees much more bent. They tend to crouch more on their knees when they're praying, and they go on their hands and knees. So for the Christians who bend to about 90 degrees, most of the time they get problems at the front of the knee, the bursitis, the prepatellar bursitis. And you can get swelling and redness and pain in that area. It makes it painful to touch. And with those, it's just a simple case of maybe using knee pads or using anti-inflammatory medication. The more you bend your knees, the more pressure you place on the cartilages. And so you can actually tear a cartilage by going into a deep knee bend, like I said, like when you're squatting. And you're much more likely to have a problem with your cartilage if you're doing the full crouching fully to bend with your hands on the ground, as Muslims tend to do. So if you find that if you put your hand on the front of the knee and you push on it and there's no problem, then you're not likely to have tendinitis or bursitis. You can feel the bone in the front of the knee is actually quite superficial. If you find that bending your knee when you're sitting down to about 90 degrees is okay, and you try and hold onto your knee and bend it fully and you get pain, then you're likely pushing on a painful cartilage on the inside of your knee. So those are the general reasons. What should they do? Well, I think they need a diagnosis, first of all, to find out where the problem lies and what can be done, especially if it's impacting on something as important as, you know, as religious practice. So, because it could be something that's fairly amenable to a minor surgical procedure, or just, you know, simple thing like knee pads. I don't know if that answers the question. If I've been too vague, if there's a comeback, I'm happy to go deeper into it.
Thank you, Theo. So I'm going to go to Ernest now. You'd like to ask your question?
You've just muted yourself again, Ernest.
I'm trying. Okay, yeah, right. Greetings. I am partaking in this Zoom meeting from Africa, so I hope you won't be referring me to a GP. I actually have the question I'm asking actually came up in the chats, but since I'm not sure you get around to answer all of them, I said that perhaps I should raise my hands. I'm 61 and I work out quite regularly in my home gym. I'm kind of addicted to maybe fast walking on my treadmill. I have noticed the onset of arthritis on my knees. And thus far, I have these knee compression braces that I wear. And I tend to get some relief from them. I notice equally that when I wake up in the mornings, they don't wake me up at night though, but when I wake up in the morning, my knees are all wobbly. So I reach out to those knee braces, and once I wear them, I feel some relief. Now, I would like to ask the question, how effective are these knee brace supports? I think they're called compression knee brace support. I got mine off Amazon. Am I just, kicking the ball down the lane, postponing the D-Day? Or how long can they really hold out before I have to do perhaps something more, go see a GP in Nigeria where I am? Thank you.
Yeah.
Thank you for your question, Ernest.
Yeah, so a few things there, Ernest. The fact that you work out regularly is very good. The fact that you're continuing to walk on the treadmill is very good. Knee braces help. They provide some support to the knee, especially if you have a minor injury. And with a minor injury, a brace to support the knee whilst you're getting over it is very good. So when a brace supports the knee, what happens is that the muscles have less work to do. So if you use a brace for a short period of time, is very good, but then you must get rid of the brace, because otherwise, if muscles don't get the stimulation they need to do the work they're supposed to do, well, they just shrink. And that provides you less support with the knee, more likely to have a minor injury. And the cycle goes on. So the lesser of two evils is to be without the knee pain and use the brace. But because you're using the brace, you must have some physiotherapy, some muscle strengthening exercises, because your muscles are working less when you have a brace on. So it's good for pain relief, but I prefer braces for injuries where, so if you have an injury, your function goes down, but you're going to heal, rather than a long-term condition where you're going to be using that brace all the time, because it does cause the knee muscles the muscles around the knee to be weaker. The reason I say you need a physiotherapist to advise you on exercises is if you have arthritis of the knee, there are certain exercises that can worsen things in terms of the pain you'll get. So you want to avoid those exercises and do some low impact strengthening exercises. And if a physiotherapist watches you doing them, they can correct any minor problems you have. So keep using the braces, otherwise you'll be in pain, but you need to do something to start strengthening the knee. So continue the treadmill walking. It's very good. It's not high impact.
Okay. This is a quick one. Someone's mum had a knee replacement last year. She now finds it hard to mobilize, even with a stick, because the knee is now painful and stiff. This is post-knee replacement. Is anything that you can advise her to do?
Yeah, well, painful knee replacements are a problem, which is why I said, whilst I was talking about knee replacements, that they're there, but I can't minimize the fact that some patients don't get a good outcome after knee replacement. My practice is partly devoted to failing knee replacements, and so I do see a lot of these patients. So there are a few things really. In the first, you'll still be on the follow-up. You mustn't be discharged from your surgeon if you're having a problem with your knee replacement. You can't be discharged. Okay. If you're not satisfied with the knee replacement, you need to keep seeing the surgeon. So I assume it's last year, so it's not within 3 months. If it's within 3 months of a knee replacement and you haven't got the bend back, we will take you back to the operating theater and just bend the knee to break down the scar tissue. After 3 months, it's less effective. Maybe there was a consideration given to manipulation, which is bending the knee, and for some reason it didn't happen. Afterwards, you can have a keyhole procedure to try and break down the scar tissue within the knee. We also have to convince ourselves all the time that there isn't a small amount of infection in the knee, so they might decide to put a needle in the knee and take some fluid out and see if there's some infection. To fully investigate a knee replacement that's causing problem within the first year can be difficult because a lot of the tests, the scans which we do, the bones are still very active at that time. But if at the end of the day, you still have problems with a knee replacement, if a problem is identified, one of the options is maybe some form of revision surgery to correct where that problem is. But if it's just a case of physiotherapy or other things holding her back, just make sure that all that has been dealt with, and maybe just accompany her to the next appointment with the surgeon and just find out what the surgeon's thoughts are as to why there's still a problem at this stage.
Okay, thank you. You mentioned infection, and we've had a question on very specifics about an infection. They've been diagnosed with inflammatory osteoarthritis, and they've been given their white cell counts, which they've put in the chat, which seems to be normal from what they can see, because they've given us what their results were and the range that they were given in that particular lab. So just to reassure you that your counts are within the range. But he's been diagnosed with inflammatory osteoarthritis, and he said, is there a reason? Do you know if there's a reason why there's a surge of knee complaints from individuals in the African Caribbean community? Because this individual had lots of friends of various ages who have knee complaints. Do you know if there's any dietary factors, environmental factors that might trigger arthritis?
Well, the short answer is no, but there's a bit of a longer answer to that. We do tend to have, as a race, slightly more knee So when we look at hip and knee problems, the big weight-bearing joints of the lower limbs, there tend to be more hip problems in the Caucasian population in terms of arthritis, and more knee problems in the African, Afro-Caribbean population. In terms of inflammatory arthritis, things like rheumatoid arthritis, the incidence is higher in the Caucasian population. Also, all arthritis tend to increase as you get older. So if you have a cohort of friends and you're all 45 and then you all turn 50 and then you all turn 55, you probably will all get more problems with arthritis. As far as I'm aware, there's nothing which is causing an increase in knee type arthritis complaints in the Black population. So you've got the spectrum from pure wear and tear osteoarthritis, which is just someone who's maybe played excessive football, had too many tackles, the knee is rough, and that's what's causing the arthritis, to rheumatoid arthritis, where there's been no damage to the knee, but the body has just started an inflammatory process and it's attacking the joints. But there's a spectrum in between, and some people have a more inflammatory type of osteoarthritis, and some people with rheumatoid arthritis have burnt out rheumatoid arthritis and it's pure wear and tear. So if you have an inflammatory type of osteoarthritis, you will usually have more episodes of swelling, more episodes of swelling, and usually more responsive to anti-inflammatory medication or joint injections. And those are the ones that respond quite well.
Thank you. So I'm going to try and get through the questions because we've got about 5 minutes left now. So this is a question that says, I'm suffering with pain in my left knee with muscular fatigue in my calf and thigh above the knee. They also have a sharp pain at the same point, which seems to have a click when extending and bending the knee. So ibuprofen as well as hot towels bring some relief, but the movement is now not as good as it was before. They started about 10 days ago and was progressively worsening. Doesn't think that there was anything out of the ordinary that precipitated the problem. Wasn't kneeling extensively or anything like that. It just started happening with pains in the knee and fatigue in the calf.
Yeah, we don't have an age, do we? No.
No age.
Okay, you said it's been there for 10 days.
Just 10 days.
Yeah.
Still here, you might want to send me your age privately if you want.
Yeah. So in terms of a knee which starts to click, I'd be keen to have the knee assessed, really. Because clicking, to me, I just need to usually make sure that there's nothing mechanical in the knee. So clicking can be due to a loose body, it can be due to a cartilage tear, it can be due to irritation behind the kneecap. But once again, depending on the age I'm looking at and depending on the appearances on an X-ray, might well lead me to say, do I need to do any further diagnostics, usually an MRI scan, to see if there's anything that can be tackled surgically, or if this is something which just needs to be rehabilitated. And I think it's an important distinction to make at an early stage, really. And a lot of this depends on the age and what we can see on physical examination of the knee and also the plain X-ray, which is why I wanted to know how old the patient is. Ibuprofen and did I get that there's been some improvement?
Yeah, it's been brought about some improvement using that, but there's still an impact on the way they're moving.
Yeah, I mean, over a period of 10 days to have a loss of range of motion in the knee, I don't like knees that don't move fully for no particular reason. If it's just pain that is stopping the end range of motion, then I'm happy that when that pain is dealt with, we can get the range of movement back. But if you have restriction in the range of movement, and it's very easy to tell, you lie down on a rigid surface and you pull the good side towards you as far as you can, and you see whether you can get the painful side to the same degree. So I think maybe they need to be assessed. The best people who assess knees outside hospital are physiotherapists. Physiotherapists do this all the time. They do this all the time. And that's what, they're very good. And depending on where you live, you might be able to self-refer into physiotherapy, the first contact physiotherapists. They're very, 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 very good. GPs have to deal with a whole range of things, from children with coughs and colds to, elderly patients who are getting dementia or chest infections or diabetes. But physiotherapists spend 90% of their time focusing on musculoskeletal problems. So they're very good. They have a lot of experience. And if you can get yourself into, if there's a self-referral service, something with clicking and the loss of range of movement, I'd be keen that you do that.
Thank you. I hope that was helpful for who asked the question. It's interesting that you say it's better to self-refer. I in the past have found it actually more difficult to see my physio than to get a physio appointment than to see a GP, because at least GPs sometimes have emergency appointments, but perhaps it's asking the right questions. So when you ring up the GP practice, you can ask whether there's a self-referral route into physiotherapy. Might provide some relief for the GPs. I just wanted to say now, thank you so much for the session. There are a couple of questions we didn't get through, and they're meant to do with why you develop osteoarthritis. And I think you covered some of that in your presentation. If people are interested, would you be able to make your slides available?
Yeah, I can do. There's nothing that's protected in them.
Yeah, so if you want to find out a little bit more information, if you contact the Caribbean African Health Network, they can provide the slides for you if you want a little bit more information. But Theo, thank you so much for your session. What we'd like now is some feedback on the sessions. And so there's a poll that you can fill in to give us some feedback. And the poll also asks for sessions that you'd like to see in the future. As I've always said, these sessions are by us, but for you. So thank you very much. And I'm going to hand over to the CAHN team now. Thank you. Thank you, Theo.
Thank you.
Hi, is there someone from CAHN who's going to do the closing? Thank you.
I'm having problems here now. I think I panic.
Hi, Rosalind. Is it okay if you could just make it full screen if you can?
Yeah, okay.
Yeah. If you can't, I'll just do it on my side for you.
Do it, please do it.
Okay, that's fine. I'll do it on my side. Just bear with me. Give me 2 seconds.
I'm trying to.
Yeah, just bear with me. I'll do it on my side. If you just stop sharing
Yeah.
your screen.
Yeah, okay.
All right.
Can you see me?
You put your
Is that
camera
okay?
on and stop sharing your screen, and I'll do it from my side.
Okay, wait, I can't find myself here. Good morning, everybody. Good afternoon. My name is Rosalind McGowan, CAHN's Counseling Service Manager. I just want to say thank you, Dr. Theophilus, for informing us in terms of knee injury and causes as well as management. Thank you for so ably educating us this morning. Also, we want to thank Dr. Ngozi for hosting alongside you. As always, she's very enabling. Okay. And also are those who are on Zoom presently and those who are on the World Wide Web as well. Our next week, we will be presenting in our health hour, Use It or Lose It, Steps to Aging Well.
Gina?
I'm very much interested in that one. And that will be held from 11 o'clock to 12:15 by Dr. Palumi. So I'm looking forward to that as well. Okay. Aging process, well-balanced nutrition. Also, our Healthy Hearts continues every Tuesday from 6 p.m. until 7:30 p.m. And this coming week is all about frozen versus thin and fresh foods, implications for health. Thank you. Following on from that, our CAHN Family and Advocacy Support Services, along with the counseling services, we are available from 9 in the morning until 9 in the evening. So you can contact us on 07710022382 or contact the Advocacy Department or the Counseling Service Department. Thank you. Our bereavement peer support group continues every second Thursday of the month. This bereavement support group was set up because so many persons were going through their different stages of grief. And so this was formed so that persons can share in a respectful and confidential space, sharing their feelings and loneliness and all that encompasses grief, as well as making friends and sharing their experiences as well. And this is fortnightly every Thursday. So you can contact me, roslyn@cahn.org.uk, or using our helpline as well, 077-10-022. Also, our Arts and Wellbeing Department, Wellbeing Service. This is facilitated by Michelle, and our hubs are based in Bolton as well as Stockport. At Bolton, it is at St. Paul's Community Center, Halliwell Road, Bolton, every Wednesday at 2 to 4 p.m. At our Stockport hub, it is based in North Reddish Community Center, every Tuesday at from 1 till 3 p.m. Thank you. Oh, let us talk about healthcare research. If you are a volunteer in the community or social enterprise or VCSEs, you're doing work in Bolton, Manchester, Oldham, and Rochdale, please feel free to contact us on research@cahn.org.uk on using the various numbers below. Thank you. Again, another piece of research. Have your say about health and care research. Are you a volunteer? Are you voluntarily in the community and social enterprise? Again, in Greater Manchester. Again, this is for you to come along and join us and hear from us. Again, you can contact us on research@cahn.org.uk. Again, individual experience of health research. Are you living in Greater Manchester? We want to understand your thoughts about engaging in healthcare research in the UK. Again, you can use those same numbers again. Thank you. This is a big one for us, cost of living survey. We need to hear your voices. We want to know how you are coping. We know at this time so many people are struggling. Again, you can contact us at research@cahn.org.uk. In terms of all our partnerships at CAHN, you can contact Sandra Yarty, email sandra@cahn.org.uk, telephone number 073-8971-0957, or CAHN. Again, our Enfield Caribbean Association, you can contact Dion John at thecah@cahn.uk. The number is below for you. And then we also have another partnership, RAFA, International Development Age, admin at rafa.org.uk in terms for contact. And here you see the number as well, phone number where you can access them. Again, we have also another partnership, the Royal Assembly of Redeemed Christian Church of God. You can contact Dr. Samuel, and his phone number is 07882-931-539. Also, our other partnership again is Croydon BME Forum. And the email address is info@bmeforum.org. Telephone number is 0208-684-3719. Thank you for coming along this afternoon and sharing with us. See you all next week.
Thank you. Bye.
Bye.
Welcome to our Caribbean and African Targeted Health Improvement Program, CATHIP Health Hour. The Caribbean and African Health Network, CAHN, along with its national partners, are incredibly pleased to continue to bring to you targeted health and well-being education delivered by Caribbean and African doctors. These health hours are all about empowering, educating, and giving space to Black people so our communities can look after themselves better. Every Saturday, our Black GPs or consultants present on those health and well-being topics that affect you, your family members, and friends. Some weeks will vary and will include other panel members such as pharmacists, specialist nurses, and faith leaders. Our health hours cover a range of topics and include mental health, heart health, women's health, reproductive and sexual health issues, men's health, respiratory problems, cancer, sickle cell, and many more. We have not forgotten to include within our health hours the many societal, cultural, religious, and racial challenges that can go hand in hand with health problems and influence how we should respond to meet health and well-being needs. The sessions are designed for you, and we want you to use the time to listen, learn, share your experiences, and ask questions to our Black doctors. During every session, we will gather your feedback so we can continue to respond to the needs of our Black community. To request any particular topic, please email health@cahn.org.uk. We encourage you to invite others to our health hour sessions. Spread the word in our community. CATHIP is funded by the National Lottery Community Fund.